We present a novel technique to manage posterior glenoid bone loss using a distal clavicle autologous bone graft secured with suture buttons. In the lateral decubitus position, a distal clavicle bone graft is harvested using a mini-open technique. The graft is placed on the back table for preparation, where it is sized and trimmed with the oscillating saw. The graft is loaded with 2 double eyelet suture buttons. This patient had a previous failed posterior banca repair. Viewing from the anterior superior portal, an elevator is used to elevate the capsulolabral tissue from the edge of the glenoid. The posterior capsulolabral complex is elevated from 5 to the 10 o'clock positions, and 2 PDS sutures are positioned on the superior and the inferior regions of the capsule to enlarge the posterior portal. These sutures are gently maintained in traction using forceps during the procedure. A curved 4.5 shaver is used to debride the glenoid neck and prepare the glenoid defect, removing scar tissue until the subchondral bone is exposed to facilitate graft union. The posterior cannula will be then located between the infraspinatus and the posterior capsulolabral complex. Below the equator of the glenoid, a 5 mm offset drill guide is used to drill a pilot hole for an all-suture anchor on the posterior glenoid defect, 5 mm medial and parallel to the glenoid surface. This will be the pilot hole for a 2.8 mm all-suture anchor on the glenoid defect, where the graft will be secured. A second all-suture anchor is located 10 mm inferiorly from the first one, also using the glenoid offset drill guide. Using these 2 all-suture anchors, the graft will be transferred with the 2 double eyelet suture buttons. A 15 mm cannula is positioned between the infraspinatus and the posterior capsule to shuttle the graft. The suture limbs from both anchors are retrieved through the cannula. These sutures are used to load the graft using the double eyelet buttons, and the graft is then tilted and shuttled using Nice knots in each of the buttons. A Nice knot is created for each suture button and used to advance the graft, tightening sequentially the sutures to shuttle the graft into the joint. A Wiesinger rod can be used from the anterior portal to push the posterior capsule as an intra-articular retractor. The graft must be positioned below the equator and flush to the glenoid surface. The Nice knots on each button are tightened, and a tensioning device is used, tightening the suture limbs 3 times up to 100 newtons, ensuring the correct compression and position of the graft arthroscopically. Finally, once the graft is secured in place, the posterior capsule is repaired on the superior glenoid edge using labral tape and a knotless anchor on a previously drilled pilot hole. This restores the posterior capsulolabral complex and renders the graft extra-articular.